Okay, well, good evening or good morning or whatever it happens to be in your part of the world. Welcome to January Grand Rounds. I'm going to turn this over to Dr. Susan Northrup, our federal air surgeon, for the opening remarks. Dr. Northrup.
All right, I'll be quick because there's a lot of material tonight, and Dr. Bendrick does a great job presenting it. But let me welcome you to the actual no kidding January Grand Rounds as opposed to the delayed December Grand Rounds. And I want to thank each and every one of you that's been helping the pilots pre-flight their medicals. It is beginning to show real fruition in speeding this whole process up for the AME and the airmen. So thank you very much. For the last 3 months, the general review time from deferral to decision has been averaging less than 30 days for the first pass folks. That means they brought everything they need to you, you've uploaded it in the system, and we've arrived at a decision. That includes weekends and holidays. So thank you very much. Another good news, the drug and alcohol first pass set is also below 30 days for the last couple of weeks. So congratulations and thank you very much. And without further ado, I hope you enjoyed this evening's presentations. And of course, we're always looking for suggestions. So Christy, back to you.
Thank you, Dr. Northrup. And I'd also like to say hello to Dr. Wyrick, our Deputy Federal Air Surgeon. I see him on video as well. So hello, Dr. Wyrick. Next slide, please, Dr. Bendrick. So why are you here tonight? We have lots of AME guide updates that Dr. Greg Bendrick, one of our medical officers, is going to discuss with you. Our objectives are to discuss the new disposition table and AASI for mitral valve disease. We're going to talk about new disposition tables and the status summary for typical atrial flutter that's been treated with ablation. We're going to discuss new disposition tables and CACIs for carotid or vertebral artery stenosis. Review the calcium scoring and or coronary CT angiography. We're going to talk about some name changes to the diabetes or hyperglycemia status summary sheet, as well as review the NF-1 AASI and what we've removed from that particular form. Next slide, please. So without further ado, I'm going to turn this over to Dr. Greg Bendrick. Dr. Bendrick.
Greetings. Thanks, Christy. I'm Dr. Bendrick, as mentioned, one of the medical officers here at the Aeromedical Certification Division at the Civil Aerospace Medical Institute in Oklahoma, where we're dealing with the snow and stuff, although today we've had some temperatures above freezing, so it's getting a little bit better out there. Been here at the FAA since 2017, so about 8.5 years now. And for the most of that time, I was full-time certification officer. About a year ago, I took over my current position, which is physician trainer. So hence one of the reasons I'm here involved with this, as well as many other things in terms of training. And then along with that, I perform quality assurance review on the physician side of the house. Likewise, I still do my share of certification, I still do my share of physician of the day duties, and so I've probably talked to a number of you on the POD calls. Before I came to FAA, I was a little over 16 years at the NASA Dryden Flight Research Center out in California on Edwards Air Force Base. I was the alternate landing site for the shuttle, and we did a lot of good aeronautical research and airborne science there. The shuttle program went away and, ended up coming here to FAA. Before NASA, I was 3 years in the private sector. And then before that, a little over 9 years in the U.S. Air Force, which is where I did my training in both aerospace medicine and occupational medicine, which are my board specialties. So tonight we have a lot about cardiology and diabetes that I've worked with primarily over the years here since coming to the FAA. So I guess that's one of the reasons they asked if I could give the talk this evening. So without further ado, we'll talk about mitral valve disease and in particular the AASI that we've now developed for that. With mitral valve disease, as with really, with most of your valvular conditions of the heart, the when the condition is mild or something less trace, okay, then we typically will warn for that. Typically, if something is moderate, whether it's mitral stenosis or mitral regurg, mitral insufficiency, aortic regurg, aortic stenosis, typically, as a rule of the FAA, if it's moderate, we're going to follow that on special issuance, and you'll echo in a office note from the cardiologist. And if it's severe, typically we're looking to deny at that point and looking for some sort of remediation. We will look at all the data, but really if the condition's into a severe range, then we typically find that aeromedical risk to be too high. So kind of in that paradigm, if you will, when we look at specifically at mitral valve disease, and specifically mitral regurgitation, mitral insufficiency. Now, we at the FAA use those two terms interchangeably, regurgitation and insufficiency, whether or not they're associated with mitral valve prolapse. And so, just be aware of that. Just as a side note, some of the folks have been around for a while or may be up to speed on your cardiology history. In the old days, there was a lot of mitral valve stenosis that was associated with the rheumatic heart disease, which was all, of course, associated with a streptococcal infection of the throat, strep pharyngitis. And then over the years, the development of antibiotics that really reduced the prevalence of not only the rheumatic heart disease, but also the mitral stenosis. We don't seem to see that very much. We'll still see it from time to time, mitral stenosis, but really what we see much more commonly in this realm is the mitral regurg, mitral insufficiency, often but not always associated with some degree of mitral valve prolapse. So as I mentioned, if we get that, and we got an echo, you guys get the echo, or gals get the echo for some reason. Maybe you heard a murmur on exam. A lot of times, this will be picked up by the AME, and AMEs, as you all should, you listen to the heart with your stethoscope, with the earpieces actually in your ears, and we've had a number where they get picked up. We've had some very interesting conditions picked up by the AMEs stuff. In any case, they get the echo if it's mild or trace, and they're asymptomatic, no shortness of breath, palpitations, chest pain, dyspnea on exertion, anything like that. Go ahead and issue them. It's a regular issuance. Please upload that echo report and any other reports you have, and note all that in block 60. Okay. Now, when we get to moderate, and for the AME, moderate and severe is pretty much the same. You got to send us the same information on in both degrees. So that's pretty straightforward. Our disposition is going to be different. As I mentioned, for severe, it's probably going to be deny. And for moderate, it's most likely, usually, going to be a special issuance. And so what we're going to want for moderate, of course, the echo report there, of course. We want a detailed clinical progress note from the cardiologist, usually the one who ordered the echo or did it, and specifically addressing any symptoms, as well as how they interpret any studies that have been performed, and whether they agree with the findings or not. That can be very helpful, especially when we're at the point of moderate to severe. We're considering the possibility of denying, hearing reading what the cardiologist has to say can be really very helpful in that line. So we want that. Now, because of mitral, the mitral valve, it's sitting there, in between the left atrium and the left ventricle. And so if you've got regurgitation, insufficiency, and you've got backflow and stuff, there's a good chance you could be getting some dilation of the left atrium. And of course, whenever we start getting dilated left atria, we're at risk of seeing atrial arrhythmias, namely our good friends AFib and AFlutter. So we're going to talk a little bit more about that here in a minute. But bottom line is for the moderate or moderate to severe mitral regurg, mitral insufficiency, We do want a 24-hour Holter with that. Some people, that they'll call, can we do a 14-day, cardiac event monitor, a Zeo patch, cardio key, whatever they get. And so, of course, certainly. More data is always better, especially if you're looking for something that doesn't happen, all the time and it's periodic, paroxysmal. Yeah, longer is better. All we really require is the 24-hour Holter. If they want to do something longer, that's fine. We're definitely happy to see that. But then you must defer the exam. Now, if everything is in the moderate range and they're having no symptoms whatsoever, and the Holter monitor is like stone cold normal, can be used in a textbook of normal physiology. Okay, that's a good case where you can give us a call here at CAME as the physician of the day, or you can call your regional flight surgeon's office. And you've got all the data there, and it's all very straightforward, all very boring. We like boring. Then we can most likely give you a verbal authorization at that time. Ideally, particularly if you're the AME record for the prior exam, you can scan and upload those reports, or have your staff scan and upload the reports, and then we can see them here on our end. And so, I be on the phone and I'm looking at reports and looking at this, and yeah, it's moderate, and this is fine, and that's fine, and no other concerns, and yeah, the mitral valve insufficiency is moderate, but then their aorta is dilated at 5.5 centimeters. Well, that's a problem. That's a whole different problem. That sort of stuff. We're looking at the whole report, but if it's all straightforward, very boring, we can most likely give you the verbal auth on that. And we'd just like to note, by the way, over the past year or so, we've had typically on Tuesdays, as most of you know, we hadn't been doing physician of the day call. Well, fortunately, our colleagues on the regions have been able to step up and do the physician of the day calls on Tuesdays and Thursdays. So that frees up then the CAMI folks to do other things like, drug and alcohol reviews and things like that. And so, yeah, shout out to my colleagues there on the regions helping out with the actual POD call. And so we're 5 days on that. Medical appeals, okay, we don't do it on Tuesdays, we surge and stuff, but for the bread and butter stuff, and certainly all this is all general review. The 5 days a week now availability on that, so that's a good thing. And like I said, you can also have the option of calling the regional flight surgeon's office, and this stuff there's very straightforward and easy to take care of. And what we'll likely do then is for the moderate, put them on an AASI for the mitral valve insufficiency. So on subsequent evaluations, then you'll be able to issue the pilot their certificate. If everything's normal, they meet all the criteria. Oh, one thing going back on that, just to note on the POD calls or the regional flight surgeon calls, if you upload the reports to the exam that you're doing and you haven't transmitted the exam yet, well, then we can't see those reports, okay? It's got to be transmitted before we can see the reports. But as I mentioned, if you're the AME of the past exam, it's okay to upload the current reports to the past exam. That's okay. And then we can actually see it here on our end, and then give you the verbal auth, and then you can transmit the current exam. That's okay. If you're not the AME of record for the past exam, then you just got to tell us. If we can make a disposition on that, that's great. If we can't, then we're just going to have to say you got to defer, and we'll try to turn that around as quick as we can. Yeah, some of the reports where they say for the AME side, if it's a mild to moderate, then consider that moderate, and defer, or ideally maybe give us a call. Likewise here, as we go to the severe category, if it's moderate to severe, consider that severe. Now, on our end, we're going to read that report very carefully. We're going to be looking at numbers. Some places are able to do various calculations. Some are not so much. Depends on the machine they're using. And if it really looks like this is really in the moderate range and stuff, okay, we'll treat it accordingly. If it really looks like it's a severe and they're kind of calling it mild, moderate to severe, we're going to treat it as severe. So anyway, for the AMEs, mild to moderate equals moderate. If moderate to severe equals severe, and then we'll deal with it on our end. So speaking of severe, if it's listed as severe insufficiency, severe regurg on the echo, or if they're having any symptoms, they're having palpitations, chest pains, occasionally getting short-winded when they go upstairs. Doc, I used to be able to go up the whole flight. Now I got to stop halfway up, like an oxygen break or something. Well then, yeah, that all bets are off. You got to defer that. We got to take a look at that, and we're going to be looking at that a little bit more carefully. The for the we of course we want all that. If it's severe, we really want the echo and a Holter monitor for that matter to be done within 12 months. So when we're in their severe range, we really need something current to look at, see exactly how we're going. When all the dust settles, if it's kind of more moderate than severe, we may look at doing like a 6-month special issuance and then getting another echo and report from the cardiologist at that point. However, if it's really severe, then we're going to deny. And at that point, we're really looking that this aeromedical risk be mitigated. And that's basically going to be with an intervention, either a valve repair or nowadays they go ahead and just do the mitral valve replacement. So whether it's repair or replacement, we want to see that risk, that severity is decreased and lessened, and then we could do that. Moving right along. I'm going to shift gears a little bit and talk about, I referred to AFib, A-flutter earlier, and when I first came to the FAA, my knowledge on the subject was that AFib pretty much equals A-flutter, and A-flutter equals AFib. So we even use the term AFib flutter, and that's the way we look at it. So if somebody had A-flutter, okay, blah, 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 well, we need to work up for AFib. Well, as it turns out, I was demonstrating my need for further education at that point, and I do that a lot. I was graced with getting further education and was told that there's actually this other subset of atrial flutter called typical A-flutter, typical atrial flutter, TAF, if you want to think of it that way. And so typical A-flutter is a different beast. It's kind of like this little, from what I understand, is a little bypass track that can lead to A-flutter. The electrophysiologists out there, they're looking at an EKG with an A-flutter pattern. Based on the pattern of the EKGs, they can say, yeah, this is a typical pattern, or it's a atypical or non-typical pattern stuff, in which case they'll take them usually to the EP lab. They'll do further testing in the lab. They'll isolate the track and then ablate it, either radiofrequency or cryoablation, however they do it. But when they do that, it seems to have a very low complication rate and a very high success rate. And that's good. And they are then, the pilot, the patient is then cured of their typical A-flutter. And that's a good thing. Okay, so now in my limited in warped brain, I guess, I think of it kind of like the inverse, almost like a Wolff-Parkinson-White thing, where Wolff-Parkinson-White, of course, is more ventricular, but similarly, if they identify the condition, do the testing, go to the EP lab, do the testing, and ablate it, then that likewise has a very high success rate and a very low complication rate. So with the, I kind of look at it like a typical A-flutter. If it's been ablated, and it's been more than 2 years ago, and they're asymptomatic and no medications required, nothing like that. We want the AME to have the pilot's cardiologist fill out the typical A-flutter treated with ablation status summary that you see here on the slide, and I'm going to advance it, and we have that right here. It was this worksheet was put together specifically for this purpose, and basically we want the cardiologist to say yes, this indeed was the diagnosis of typical A-flutter. Okay, and then the date of ablation. Was it more than 2 years ago? We want a Holter monitor that was done no sooner than 90 days after the ablation. Now, if the ablation was, 3 years ago, and they did the Holter monitor, 2.5 years ago, that's okay. We'll accept that if the ablation was done more than 2 years ago. No meds, no symptoms, no clinical concerns. They do all that. Everything's on the left side there in the yes category in the white boxes, the clear boxes, like most of these things that we've put together now with the FAA. Everything's yes, good to go. Scan that sheet and upload it to the exam. Note that in block 60 and tell the pilot to have a nice flight. Okay. Now, if it's less than 2 years ago, we still want the DCPN from the cardiologist. Of course, we want the procedure report. The DCPN from the cardiologist and Holter monitor no sooner than 90 days after the event. Then we had some discussion about this. We really do want an echo at this point because we want to see kind of what the atria are looking like and if there's any valvular concerns which can be associated with that. So we want for this we want the AME to defer on that, and then we'll make a decision on our end. If everything looks good, chances are we're going to issue the regular issuance, letter of eligibility, regular issuance with a warning for the condition and no more. But we really need to review that on our end, because if you go to row C here on the AME guide for the typical A-flutter, if it's really not typical A-flutter, if it's something else, then it's basically in the AFib category. And at that point, we want all the workup that we require for AFib. That's a different page in the AME guide. We want the AFib, A-flutter status summary and all that. And then for the initial defer on that. A lot of times we're able to do an ASI for the AFib, A-flutter, but we need that, including the sleep study and all that sort of stuff that goes with AFib. So key point there, take home point is that there is this entity called typical A-flutter. And if it's ablated and it's successful, then there's a good chance we don't have to follow it after that. More than 2 years ago, have the cardiologist fill out the summary sheet and its regular issuance. Less than 2 years ago, get the required reports, defer it to us, and typically we could turn that around pretty quickly. Okay, and let me demonstrate my challenges here with technology. Okay, I'm not. Okay, there we go. Okay, there we go. Okay. So moving right along on the next level of our cardiovascular journey, we now have a khaki for carotid or vertebral artery disease. So typically the pilot, kind of like the echoes, they'll come in with their report of the carotid ultrasound. They got it for whatever reason. Now, if they got the carotid ultrasound because they had a TIA or a stroke, okay, we're done. We got to go down that pathway. This does not apply to those conditions. Okay. And also be aware, okay, sometimes the diagnosis of the presenting symptoms gets kind of downgraded to transient global amnesia or something like that. And it's kind of like, no, if the ER doc thought it was a TIA, then that's what we're going with. And we're going to do the neural workflow and we'll take it from there. So just keep that in mind. But if they haven't had any symptoms like that, and somebody somewhere thought it was a good idea to get a carotid ultrasound, and they have less than 50% in their carotids, and or the vertebral arteries that they're doing there, less than 50%, either side, both sides together, whatever, that's fine. We're good. So 49% or less, otherwise known as less than 50%. Okay. Then just verify that, make sure they're having no symptoms. And the other thing is that they can't be on a DOAC or a NOAC, Eliquis, Pradaxa, Xarelto, can't be on it whether it's for another condition or not. Okay, so if they're on that, this does not apply. But if that's the case, 49% or less, have a nice flight. Tell us about it in block 60. Upload the reports and issue the certificate, assuming there's no other conditions going on. If it is 50 to 80%, or for the engineers out there, 50 to 79%, less than 80%. And again, no history of TIA or stroke. They're not on anticoagulation in the formal sense of the word, either, Eliquis, Pradaxa, Xarelto, whatever, or Coumadin. They're not on that. If they are on that or any symptoms and stuff, okay, this does not apply. But they're not on any coagulation. It's okay for them to be on aspirin and or Plavix or Effient, Brilinta, any of the antiplatelet therapies. That's okay. The actual formal anticoagulation, no, is not okay for the CACI. That'll go into some other book. But we want detailed clinical progress note, of course, from the treating physician, whether it's a neurologist or not. And we want the imaging, okay? And the imaging could be the ultrasound. If they get a CT angiogram, that's fine. If they get a magnetic resonance angiogram, that's fine. We want that done, within the previous year. And that's fine. We don't require a CTA or an MRA necessarily. We just require the imaging. Usually it's going to be an ultrasound. But no formal coagulation, only the antiplatelet therapy, no symptoms, no history of TIA or stroke, less than 80%, but more than 50% or more, then CACI. And we will have the CACI worksheet right here. So as you can see, no symptoms. And we continue the CACI as long as there's no significant increase in the stenosis that prompts any kind of change in treatment or surveillance. So, 1 year they're calling it, maybe 50%. The next year they're calling it, okay, well, it's not quite 70%, maybe 60%. No change in treatment, no change in surveillance, whatever. Okay, that's fine. But the minute where the treating physician is talking about, well, we need to do this more frequently, or I'm going to refer you to the neurosurgeon or the vascular surgeon to talk about, surgery, or, we need to do something different now, well, then that CACI doesn't apply anymore. Got it. We want all those reports and you'll need to defer. But it's likewise, if they've had surgery, this does not apply until at least 2 years after the surgery. As I mentioned, 79% or less. If it's less than 50%, it's a regular issuance. And they're on no formal anticoagulation, just the antiplatelet therapy. And they could be on dual antiplatelet therapy. That's okay. That's fine. But no formal anticoagulation. Then that's the CACI. And hopefully we make that a little bit easier for folks going forward. Of course, row C, if it's 80% or more, they're on formal anticoagulation for any reason, whether it's for the vertebral stenosis or anything else. Certainly, if the treating physician is recommending surgery, well, then, we're going to say, yeah, we really want you to get the surgery to mitigate the aeromedical risk, which is present if you don't have the surgery. And of course, if there's any symptoms or history of TIA, CBA and stuff. And so we want that. And keep also in mind that if they've got significant atherosclerosis in the carotid and or the vertebral arteries, there's a good chance they've got significant atherosclerosis somewhere else. So we do want a cardiovascular risk assessment, basically a clinical, evaluation and the lab work. We don't necessarily require a stress test just for carotid significant or severe carotid or vertebral artery disease. But if the cardiologist thinks that's indicated, well, obviously we're going to want that also. So, but that's hopefully will help out with the carotid or vertebral artery situation. Going to the next level, it's sort of like climbing Mount Everest here. We're going to, the next base camp on our cardiovascular climb up the mountain. And this is the one, I guess it's forcing itself on becoming one of my favorite topics. I talked about this in the grand rounds last May, I guess, in 2025. And it was in response to, over the years, we've been seeing pilots getting calcium scores and or coronary CT angiography. In the old days, like 10 years ago, it was just calcium scores, but nowadays they actually go to get screened with the coronary CTA, and then they'll do the calcium score with that. Okay, whatever, we'll take what we get. When AME have asked me, is this a medical evaluation, a medical test, something that the AME or that the airman needs to report on their AME exam, I would say yes, it is, a medical visit, if you will, even if it was, a screening thing offered, when they read the billboard somewhere driving home. But like any test, we don't require a coronary calcium score for pilot risk assessment. Okay, that's actually been discussed, but we don't do that currently. However, if the pilot gets one done, as the old adage goes, if you ask the question, you better be ready for the answer. And the answer for the FAA side, and this differs from clinical medicine, but the answer from the FAA side is, as you can see here on the screen under calcium score, if they're a first or second class pilot and their calcium score is over 400, we really, really want a cardiac cath. Basically, we require a cardiac cath. We will accept the coronary CT angiogram, but everybody listen up. We will accept it only if we get the coronary CT FFR with that. And basically, it's FFR, fractional flow reserve. And it's a way that they can look at the flow through the artery of the dye and see across the stenosis and measure the flow and the pressure before the stenosis and the flow and pressure after the stenosis, and then they do a ratio of the two. And so it's fractional flow reserve. And it's you come up with a number between 0 and 1, and the general consensus on the CTFFR is that if it's below 0.80, then that's considered a significant drop, and that reflects an obstructive stenosis, an obstructive lesion. Okay. Now, why do we insist on that if they go down the coronary CTA route? That's because, okay, with an invasive cath, of course, they go in with a catheter and they inject dye into the arteries of the heart, and you see what you see, and stuff. Also, if there's a significant obstruction, you're in a position to insert a stent if that's indicated and revascularize the condition. But with a coronary CT angiogram, it's a peripheral IV. The technician injects the contrast, the radioactive contrast through the peripheral artery, and then the CT scanner does its slices and takes pictures that way. So it's helpful, but it's not the same thing as an invasive cardiac cath. It sees it'll see the hard plaque with calcium, but it's the soft plaque that kills you, as they say, and leads to the plaque rupture and often the sudden cardiac events. And so it'll see some of that, but it won't necessarily see it all. And so the coronary CTA is just, it's really, that's all it is. It's meant to be, is a screening test and stuff. Now, what they can do with that data, though, is that they can do the FFR based on the CT data, based on the flow. Here's the problem, okay? Most, virtually all of your coronary CTA facilities can't do CT-FFR, okay? So what they got to do is send it to another entity, a company, that all they do is CT-FFR. They do the measurements and send it back to whoever sent them the data. Sometimes the data they just can't run it on, and they'll say that, but most of the time they can do CT-FFR. Yes, there is a fee for this. There's a charge for this, and insurance companies typically have fairly specific clinical criteria under which they'll pay for the CT-FFR. So somebody's going to end up getting a bill for this, and usually that's going to be the pilot. And so there's a little bit of a logistical hurdle there in getting the CT-FFR. But if they get the CT-FFR, and if it's all shown to be non-obstructive, i.e. 0.80 or above, we will accept that. We're still going to follow them, but we'll accept it. And I'm hitting CT-FFR kind of hard because we say we will accept an invasive cath or coronary CTA with CT-FFR. What the pilots hear is we will accept an invasive cath or a coronary CTA. Okay. They don't hear the CT-FFR part. And then so they send that in and we say, well, okay, that's not sufficient. We really need an invasive cath or a CTA with the CT-FFR. The other thing, and I may be a little biased here, but the fact is that you see obstruction on your CT-FFR. Well, now you got to go to the cath lab and get that revascularized. If you're in the cath lab already for the initial test, you're already there, and they can get it revascularized. Most of the time they can get it revascularized. Sometimes they end up needing bypassed, but a lot of times they can put in one or more stents. And then, you wait the 3 months, you get the post-event cath, the stress test, all that usual stuff. And the pilot usually can get back to flying that much sooner. We go through the CT-FFR, and then they got to get the, the thing, and then they got to get the cath, and then wait. Well, they're just pushed back that much further. And as an aside, the data has shown that if your calcium score is over 400, your risk of major adverse cardiac events, which is presenting to medical attention with anginal chest pain, myocardial infarction, or sudden cardiac death, which is a pretty hard endpoint. The risk of those things within the year or certainly over the several years following is really not trivial, and it's just arithmetically unacceptable. And these are sudden or subtle incapacitating events. And so if you're a professional pilot, basically first or second class certificate holder, and your score is over 400, you're at an arithmetically unacceptably high risk until that gets mitigated. So that's what we've been doing for a while. We presented that at the Grand Rounds last May, and then now this is going to be officially put into the AME guide. So if the insurance companies say, well, we're not going to pay for a cath, then you can say, well, hey, this is an FAA requirement for this professional pilot. Now, so that's kind of generated a lot of discussion, but it's amazing how many times we see significant, severe disease. I mean, they're like one platelet away from, their left anterior descending becoming the widowmaker, and they get the thing, and they get the cath, and life is good. I'm still waiting for the shower of letters thanking us for saving their lives. But anyway, I won't hold my breath. But it's good. I mean, it's good medicine. It's a good thing to do from aerospace medicine perspective. Now, if it's between 100, above 100, but up into and including 400, all it requires a nuclear exercise stress test. We call it an RS, radionuclide stress test. So that's what RS means. Of note, though, even if they're third class, and their score, certainly if it's over 400, but even if it's 100 to 400, we will ask for the nuke stress test, because a lot of times the plain stress test just doesn't give you the information. It's the electrical tracings are non-interpretable due to bundle branch blocks or artifact, whatever. And this is a non-trivial risk. And so we do insist on the nuclear stress test with that. If they're under 100, that's fine. The risk is acceptable, and you can issue the certificate with that. You can see the parameters over on the coronary CTA side, on the right side of the chart here. But that doesn't seem to generate, for some reason, as much discussion as the simple calcium score. Now, let's say they get it done. The CTFFR shows no obstruction and stuff. Well, that's good, but chances are we are still going to follow them, except with some really rare circumstances. We're going to follow them on either an AASI or SI for the coronary artery disease. Sometimes we'll require periodic stress testings. Usually we won't. So hopefully that helps clarify things. That'll be going into the AME, or it's already in the AME guide now as of this afternoon. So that's that. One thing just for was it semantic purposes, our sheet for diabetes was labeled diabetes on oral medications, and we would get calls from time to time, on POD call. This guy, he's now on Ozempic, or he's now on Wegovy, Mounjaro, whatever. And of course, those are injectable medications. So can I still use, can I still do the ASI? Can I still use worksheet? The answer is yes. Our big concern is insulin, whether it's third class or whether it's first or second. And the concern there is, of course, hypoglycemia and its cognitive effects. For the non-insulin injectables and the oral medications, much less frequent issues with hypoglycemia, and so we're okay with those generally, using that combination of sheets that's in the AME guide, combination of med on the sheet in the AME guide. But we've changed the worksheet then to just say diabetes or hyperglycemia on medications. Okay. If it's insulin is the medication, whole different workflow, and we go down that. But we just clarified that it doesn't have to be oral per se. And then finally here, for all those folks who see pilots with neurofibromatosis type 1, I'm being a little sarcastic, not a lot, but we do see them. We see everything here. But anyway, we see neurofibromatosis. In the past, we would require an eye eval, and it would be an SI, but now we've changed that to the ASI without. We don't require the eye eval each year, just the detailed clinical progress note from the neurologist. We'd like it to be current, which means within 90 days. And we just want to verify that they're not having any new symptoms, signs, any new diagnosis, no significant progression of disease, but we no longer require the eye eval at that point. And with that, I am done. Yeah, I will wait for the applause to die down now that I'm done speaking, but I'd be happy to answer questions if they have any, or I'll turn it over to Christy.
As always, we just like to remind you that if you have suggestions for AME guide improvement, you can send an email to ameguide@faa.gov. Keep in mind that this box does not answer case questions, but I do know that the folks that work on the AME guide have been working really hard to improve it just in a little over a year and a half that I've been with the team. So I believe that is the last slide. Dr. Northrup or Dr. Wyrick, would either of you like to say anything before we close out?
Sure. You might have noticed a note in the chat. Today is the 40th anniversary of the Space Shuttle Challenger disaster. We learned a lot in the space program based on the investigation of that incident. But please take a moment of your time to just think about them and the things that we learned and the people that lost their lives in that incident. Further, tomorrow is the 1-year anniversary of the Washington National Midair. If you haven't had a chance to take a look at the NTSB report, lots to be learned from that incident as well.
Thank you, ma'am. Okay, if you are not an FAA employee, this concludes our session of Grand Rounds. Please go ahead and log yourself out. For those of you that are FAA employees, stand by and we'll be going into the breakout room for the debrief. Thank you all for joining us. Thank you for being in AME, and thank you for your commitment to aviation safety.